So let's get back to our agenda, everyone. While we're waiting for other participants to join in, so we have three agenda today. It's public seminar with our esteemed speaker, Carlos Alberto Montenegro and Felipe Mejia Medina from Heidelberg Institute of Global Health and Econex. So please don't forget to change your name to name an institution so we know and we can connect with you better during the session. So, introducing a little about our speakers, Felipe Mejia Medina is a Colombian public health professional. He's specializing in AI, and you might be very familiar with him because he's been with a lot of TDR Global Asia activities on AI. He leads the AI and digital health practice at Eco Consultancy and has advised national ministries and WHO on AI implementation and ethical frameworks. He holds a master in international health from Heidelberg and is completing a master's in bioethics. Wow, it's really great, and has been admitted to PhD in global health and AI. So you can see his LinkedIn, and with him also his partner Carlos Montenegro Quinones. Carlos, I'm very sorry if I pronounce it wrong. Carlos holds a BSc in biology from USAC Guatemala and has an MSc in international health from Heidelberg. He's currently pursuing a doctorate in global health, and he leads a systematic review, consultancies, and AI-driven research training, which he integrates reproducible methodologies and ethical AI applications in public and environmental health. You can connect with them through their LinkedIn. They're very amazing and they share a lot of AI. And perhaps some of you are already familiar with their class. So without further ado, Carlos and Felipe, the floor is yours. Thank you so much.
Okay, Carlos is gonna be sharing the presentation because I'm currently in Tanzania and my connection is not particularly the best. I just shared my LinkedIn and was just about to share Carlos as well. Carlos's link, it's right here, our LinkedIn, in case you want to have it. So thank you so much. Okay, can you just put it in full screen?
Yes, a moment.
To the top right. Okay, perfect. Okay, I hope I'm seeing it correctly. I hope everyone is seeing it as well. So welcome everyone to this TDR Global Public Seminar. Today we are discussing a critical convergence in global health. Basically, the ethical and responsible use of AI, artificial intelligence, that we hear over and over and over in research on poverty-related diseases, which is the main focus of TDR. I am Felipe Mejia Medina, Colombian, and I am joined by my colleague Carlos Montenegro, Guatemalan. We are presenting this on behalf of the Heidelberg Institute of Global Health and Eco Next Consultancy. Basically, as we move through this session, we will try to explore not just only the technical potential of artificial intelligence of AI, but also the governance and some ethical frameworks that are available required to deploy it safely in the global south. This is all about south and south collaboration. We are living across our Asia, Africa, and Latin American nodes, and we thank our partners, TDR, and all of who are just coming to this session for their support. So thank you so much.
Okay, so if we start, we would like to set the ground before going into our topic at hand. So basically, something that probably we all know, but is important to remember, understand, is the role of AI. So we must first conceptualize the problem we are trying to solve. So we are not just fighting biology, we are fighting a cycle as well. So as you can see here in this diagram that we have here, the relationship between poverty and disease is reinforcing mechanism. So As always, or as usually as it is with most diseases, it starts with risk exposure, which is basically inadequate housing, lack of clean water, exposed to poor to infection. So this, in turn, leads to economic depletion. Depletion, which where high treatment costs and lost labor productivity drain household resources and affects most of the poor. Finally, systemic persistence, what we see at the end, is sets in without intervention. Socioeconomic barriers prevent recovery. So keeping communities trapped, and this is a vicious cycle that most people cannot get out of. So our research cannot just target the pathogen itself, it must address the cycle of deprivation that fuels the infection in the first place. So we start from there. And then we need to really speak of poverty related diseases. We are looking at a diverse and diverse landscape. So categorized into three primary groups. Group 1, which we already know very well, the big three, HIV/AIDS, tuberculosis, and malaria, characterized by high treatment durations and deep labor productivity losses. We know very well. Then Group 2, we could say, covers all NTDs, neglected tropical diseases. We are talking Chagas, leprosy, and a myriad of diseases affecting mainly the poor. The primary impact here is often chronic disability and the social ostracization that follows disfigurement in the people affected by these diseases. And finally, group 3, we have categorized in zoonotic childhood infections like rabies or measles, very prominent right now. And we also added some non communicable diseases because all these directly impact agricultural assets, rural economic development, and basically understanding these distinct categories is vital because AI applications will differ significantly for each group. And then we had to take into account economic impacts as well, because the human cost of these diseases is matched by a devastating economic toll. So let's look a little bit of the data we have here. It's just a, a small brush of what is out there. So basically, for TB, for tuberculosis, WHO patient cost surveys reveal that nearly half of affected households face catastrophic total costs. So, meaning the disease consumes around over 20% of their national income, and for drug resistant strains, it rises up to 82%. Meanwhile, zoonotic diseases by itself, like dog mediated rabies, for example, cost the global economy an estimated $8.6 billion annually. And regarding NTDs, something that we all know, the scale is massive. Over 1 billion people, according to WHO, require interventions. So these numbers really prove that poverty related diseases are not just health issues, they are macroeconomic crises that perpetuate inequality, something that we know and most people are affected. And together with this, what enhances or makes the problem even bigger is compound biological burdens. Because complicating this picture is the reality of pathogen synergy, something that we have studied before. In the real world, these diseases rarely exist in isolation, something that we have seen before. So they coexist and amplify one another. For example, research shows that malaria infection can significantly increases the viral load of HIV positive individuals. So what it does this is facilitates transmission, and conversely, HIV infection reduces a mother's immunity to malaria. So this will create severe risk for both maternal and infant health. Okay, so basically this creates a compounded biological and economic burden. Therefore, our AI models cannot be single disease focused. We always need to think about multidisciplinary approaches that can account for these interactions and treat the patient holistically rather than just isolated pathogens. So, with this in mind, before we dive into the technology, we must really confront a fundamental ethical tension. As you see on the screen right now, where we're projecting, we have to ask ourselves this question. If, for example, AI can predict exactly which neighborhoods will fall into a poverty disease trap, right? Is it more ethical to prioritize medical interventions to save lives now, or to divert those resources toward the non medical socioeconomic factors that the AI can identify as the root cause? Let's say access to water and sanitation, for example. So, this question of what to prioritize is not hypothetical. So AI gives us the power to identify root causes nowadays with unprecedented precision. But does this foresight give us the moral mandate to shift funding away from immediate treatment? So while we go ahead with this presentation, please keep in mind the dilemma as we examine the tools that we're going to show you today. Felipe, oh, you're muted.
I am muted. I was talking to myself. So thank you, Carlos. Now let's get into AI as a force multiplier, basically moving from the ethical challenge to the technological solution. We view AI as a force multiplier, the potential that it might have in global health. When we use this term, we are describing AI's potential to bypass traditional bottlenecks in human resources and infrastructure. And we have to think that it is not just automation, it is about expanding our capacity as global health professionals and in global health, international and planetary health systems to function effectively despite the constraints that it might have, whether it is in a remote clinic or a national ministry in our countries. AI is indeed transforming from these peripheral experiments to a central pillar. So, for example, here we have some options. The first critical domain is advanced diagnostics. Here we have the concept of augmented intelligence that enables frontline workers to identify complex conditions like skin and TDs and leprosy using nothing more than standard mobile devices, at least devices that have a camera. Then we have another potential that is epidemiological surveillance. AI is uniquely, definitely capable of integrating this meteorological data, such as rainfall or such as temperature, for example, with human mobility patterns to predict outbreaks weeks before they peak. It was already done before AI, but with AI, it has been enhanced to do this surveillance. And finally, another great example, becoming very famous, it actually won the Nobel Prize 2 years ago, precisely because of these possibilities, genomic research. We are using AI to automate the identification of genetic variants and predict the protein structures of emerging pathogens. This ideally will allow us to track resistance markers in real time, also creating new medicines, new drugs, effectively buying us the time against evolving biological threats. The other possibility next would be the second domain focuses on efficiency for drug development. As I just mentioned, AI models have been created and to trying to model the interactions between compounds and pathogenic proteins, which should facilitate the discovery of new therapeutic candidates for neglected diseases in general across global health, but in this case for neglected diseases. In program targeting, for example, artificial intelligence serves as a decision support tool, helping us, the global health professionals, identifying high risk areas and optimize exactly where to send teams and supplies. This naturally extend to health system operations. At the end, it's all also about administrative things, where we can use all of these AI models for staffing optimization, for managing patient flow in hospitals or in clinics, and modeling service coverage, which is at the peak of the pandemic was one of the biggest needs. By streamlining referral pathways, we ensure that scarce medical resources, that is a common situation in our countries, are utilized where they can have the greatest impact. We also have some possibilities. Next, Carlos, in logistics, vector control, and evidence. This would be our final set of applications that we're showing here, but we can always find some others. But those ones are the key ones. These applications address the infrastructure of health delivery. So, for example, in supply chain, that's something that sometimes we don't think that much. We always think about clinical services on the actual services of public health. But in supply chain, AI is critical for predicting stockouts and monitoring cold change, for example, to optimize last mile distribution. That was key also for the pandemic. For vector control, we adopt a One Health analytics approach. Now, One Health is a very important topic, integrating entomological, climate, and land use data to guide interventions against arboviruses. And lastly, AI is also transforming evidence synthesis. This is something that it's actually getting a lot of tracking with some discussions, ethical discussions, but it's happening by assisting in systematic review screening and creating living evidence maps. AI indeed accelerates the research process itself. This ensures that our guidelines and guardrails are built upon the most current comprehensive scientific data available. That's also a problem, having way too much evidence and then gathering it all to facilitate taking decisions. Next, I think someone has a mic on. Okay, I think there is a mic on. If the person who has the mic on can help us out. Yes, awesome.
Already
Thank
did.
you. Super. Thank you so much. Then we have to think about next, please. We have to think about the what's the in the other side, right? So the force multiplier, but there is a moral hazard. This is a question that we might have to think about, and how, however, this efficiency brings us to our second major ethical discussion, right? We must ask ourselves a difficult question that we are actually showing here. If AI becomes a highly effective force multiplier that allows fewer health workers to treat more people, does this indeed empower local health systems? Or at the end, it's providing a moral excuse for governments, for policymakers, for decision makers to reduce investments in medical education and rural infrastructure? Efficiency should not only become a justification for austerity. If AI leads to budget cuts rather than service expansion, we may, without even noticing, weaken the very health systems that we intend, that we want to strengthen. Let's check some of the barriers to adoption. Next, please. Despite the potential, we face significant barriers indeed to adoption in low resource settings. Yeah, because we come from the global south. Many of us are coming from the global south. First, we have data availability. Ecosystems are often sparse and fragmented with low quality and non representative data sets that lead to domain shift. The always famous problem of interoperability. It's such a word that it's been said for years already, and we're still facing the same problem. Incompatible systems and a lack of standards make integration costly and very difficult indeed. Third, we cannot ignore infrastructure because AI depends on just the baseline of some infrastructure, unreliable power and internet electricity, along with limited hardware, fundamentally constrain where AI can be deployed. And also, definitely, we also need to mention there is the skills gap. We do face indeed workforce shortages and limited institutional readiness to manage these advanced tools. So it's not only about having the tools, but also having the people, right? Knowing how to use these tools. Without addressing these foundational layers, high tech solutions at the end will fail. Next. Correct. We are in barriers to adoption, governance, and trust. So the barriers continue with workflow integration. If tools at the end have a poor fit with real world, where is exactly where we want to do things, workflows, or lack localization, change management becomes impossible. Governance problems, that is, many regions suffer from regulatory capacity constraints and unresolved issues regarding data privacy and sovereignty. We have another mic on. Super, thank you. This fits into our crisis of trust and transparency, the black box nature of algorithms, where we don't know why they take the decisions that they take, creates skepticism and unclear accountability, leaves us wondering who's liable when things go wrong, who's responsible if something goes wrong, if we don't actually understand how the decision process was made. Lastly, financial sustainability is indeed a major hurdle. High upfront costs, hidden operational expenses, and funding misalignment often doom projects once the initial grant money runs out. So there's money for the beginning, but it's just not um, thought about making it sustainable over time once the initial budget runs out. Next, we have then the barriers to adoption. That would be our final set of barriers that we're just showing here. And it's procurement challenges that include opaque contracts and the risk of vendor lock-in, where public sectors lack the capacity to negotiate for terms. We also face the issue of monitoring and scale. Models suffer from drift in dynamic settings, and insufficient post-deployment evaluation leads to what it is called pilotitis, right? This having pilot after pilot after pilot, right? Where successful pilots fail to generalize, to make it available across countries. Finally, cybersecurity, which is absolutely critical. Weak security controls and limited incident response capabilities mean that interconnecting our systems can actually amplify risks, exposing sensitive health data to new threats, which is something that, of course, we want to avoid. Let's go to the next slide. This brings us to a profound ethical dilemma regarding data ownership versus public safety. As we see here, let's take a look at this question. If a nation restricts its health data to ensure data sovereignty, but this delay shows the development of an AI model that could eliminate a cross-border disease, who is responsible for the lives lost during that delay? The nation protected its data or the community demanding access? This tension between sovereignty and collective health, while protecting national data from extraction is crucial, of course, that is the whole idea of owning, being empowered by the data, but owning our data, we must also determine at what point protectionism becomes an obstacle to saving lives in a global health emergency. Let's check now some cases. Let's go to the next one. So here we have the case study. This is a TB in Africa. We're going to be grounding these theoretical discussions in reality, and we will now examine our first regional case study. We are looking at the application of predictive mapping for tuberculosis in Central African Republic. So let's go to the next slide. What is the problem? In the Central African Republic, specifically in Bangui, the problem is threefold. First, transmission risk amplifiers are severe. TB risk is driven by poverty, high HIV prevalence, malnutrition, and overcrowding linked to conflict. Then we have a second problem, surveillance gaps. That is because the National TB program reported a large gap of missing cases, indicating significant underdiagnosis due to the reliance on traditional passive surveillance. And finally, the spatial disparity. Clinic coverage is uneven, with fewer facilities in the north and east, leading to notification rates that reflect access to care rather than the actual spread of the disease. Let's see then in the next slide how AI is integrated. To address this, the team built a digital epidemiological representation of TB across the city. They integrated aggregated program data, specifically testing positivity rates, with contextual covariates like population, density, water access, and literacy. This allowed the model to predict TB positivity even in areas with missing observations. The output classified city tiles into low, medium, or high risk using specific threshold. This fine-tuning of the national TB program certification supports precise resource allocation, identifying localities with high unmet needs that traditional methods had missed. Let's check then now some ethical tensions of using AI for this case. However, this success highlights critical ethical tensions. First, regarding oversight, because the data was aggregated, formal ethical approval was not necessarily required, yet we must ask if independent review is needed when analytics directly influence resource allocation. Second is the risk of misclassification. The model relies on assumptions that may conflate access to care with transmission risk, potentially stigmatizing, this is key, or deprioritizing certain communities based on biased signals, false positives or false negatives. Finally, transparency. The use of a proprietary platform raises questions about accountability. We must ensure that performance reporting and validation are open so we know exactly how these operational decisions are being made.
Okay, so let's move on a little bit to home, close to my home. And we're going to see the second study case, which is Chagas vector identification via smartphone in Latin America countries. So, this initiative addresses a critical bottleneck in the control of this neglected tropical disease, vector identification. And basically, it's not only for Chagas, this vector identification bottleneck has been prevalent in other diseases, vector-borne diseases. In many endemic regions, spotting this kissing bug or the triatomines is the first step in prevention. However, as we will see in a moment, relying solely on human expertise for this task is becoming increasingly difficult because there has been a scarce of taxonomists in general around the world. So, this case demonstrates how mobile technology can bridge the gap between community surveillance and expert entomology. Let's go. So the core problem here is the taxonomic impediment, right? So controlling Chagas depends entirely on knowing which specific Tratomine species are present in a home. But the expertise required to identify them is scarce, nowadays more. Surveillance and response systems are weak across the parts of Americas. Diagnosis and treatment, because of this, often come too late, making effective vector surveillance a practical necessity. So the logistical challenge is massive in this case. Providing consistent, scalable identification support across such vast regions is nearly impossible with human resources alone, right? That this is very, very difficult situation. So this makes automation not just a luxury, but in this case, an attractive, scalable necessity. So to solve this project, basically, the researchers turned to deep learning. They train an image classifier using Google's TensorFlow or unstandardized photos of triatomines. Specifically, 12 Mexican and 38 Brazilian species. So on these results were promising because the base model achieved accuracy rates of around 82% for Mexico and nearly 87% for Brazil, already outperforming prior statistical classifiers. But there was even an additional breakthrough in this case when context awareness was added and adding geographical distribution data to the model, effectively telling, for example, the AI which species are local to the user, which species are local to this region in Mexico or this region in Brazil, the accuracy jumped to nearly 96% for Mexico and almost 99% for Brazil, making incredible results, to be honest. But despite this accuracy, ethical tensions still remain in this project. First, mainly is the harm from misclassification. Even with 99% accuracy, problem species do exist, right? We have similar triatomine species that sometimes, even for expertise taxonomists, are really hard to identify. Then, in this case, if used operationally, a single misidentification could misdirect control resources or leave families at risk. Second, this relies on citizen science, which is very helpful, but some tensions can arise. So, in citizen science, photos taken by residents on ordinary phones is what actually happens here. And this raises the governance questions. Do participants truly understand how their data is being used? And then the other question is, are there privacy risks if location metadata is shared? So these are very difficult questions to answer. And finally, there is a duty of transparency. We must communicate uncertainty to users because no model is 100% certain, and clearly define who is responsible when an app's output drives a public health intervention. Because the AI by itself cannot be held accountable, someone or some institution has to be held accountable in this scenario. So, despite being a very effective project, as you can see here, still, because of the way it was done, because we're using AI, something relatively new, tension still arise. And from this, we're going to jump to the other case study, which is AI haze early warning systems for outbreaks. Our third, and this is the third and final case we're going to look in today, especially this is for Thailand. Here we look at the integration of AI in enhanced early warning system, right? So within national digital surveillance, this example shifts our focus from diagnostic to system-wide alertness. It explores how machine learning can modernize traditional reporting structures, moving from reactive data collection to proactive real-time outbreak detection, something that we all want at the end. Now, in this case, the challenge was fragmentation. It is. The country needed faster, more integrated outbreak detection across multiple streams, case based, syndromic, and even event based surveillance. However, as we know, traditional manual workflows were causing dangerous delays in detection and decision making. The system has historically, not only in Thailand, but some other places in the south mainly, were causing dangerous delays in detection and decision making. So, in this case, relied the system on separated databases and weekly, often offline reporting. This constrained national situational awareness, creating a blind spot where signals were lost in the noise, right? So maybe was this makes a lot more difficult to really identify effectively outbreaks before time. So there was an urgent operational need to disseminate timely information to the right users. So we're talking about frontline staff to national leadership so that data could translate into immediate actions. Okay, so what was the solution? The solution was to integrate AI directly into the surveillance workflow. They implemented AI-enhanced early warning system that used time series forecasting to predict expected trends and flag unusual deviations. But the real innovation with this was in the delivery. Instead of dashboard, a static dashboard, we have flag signals are pushed as outbreak notifications directly to public health authorities through the line messaging application. So we're not just seeing a map with, conversing different variables. We are translating this already to message about regarding outbreaks. So this ensures rapid response. The outcome has been a measurable improvement in reporting coverage and timeless, specifically achieving reporting within 7 days. Now this is amazing, to be honest, with having reporting in 7 days or less, which support far more responsive surveillance workflows than in previous paper-based methods. Now, despite these achievements and results, speed actually comes with ethical risks. First, there is the issue of data privacy, right? The system handles individual cases and data from hospitals, raising concerns about re-identification, access control, and secondary use. Second, there is a question of accountability, which is a question from before as well. Because these were routine mission works, formal ethics review was not required. However, we really must ask ourselves what level of independent oversight is appropriate when AI alerts can directly influence public health actions. And finally, we face the risk of false alerts. Without robust validation or explainability, incorrect or opaque alerts can misdirect what we already have as scarce resources and sadly erode the trust of the very health workers we are trying to empower. And trust erosion is really prevalent in communities. Now, it is really hard to create trust. I have seen this from my experience in the field working with dengue, and takes times, years to create this trust. And if we wrote it like this, then probably it's going to create a more difficult situation for the health workers in the field, something that we really need to take into account. So all this brings us to a complex ethical discussion about the human in the loop, right? So let's consider this scenario, for example. If an AI is 90% accurate, but the slowest link is a human health worker who fails to act on a notification, is the ethical failure really in the technology design for being too fast or in the system for being too slow? The question really here is where accountability truly lies. Is it fair to blame a digitally overburdened health worker for missing an alert? Or is the AI developer responsible for creating a tool that ignores the operational realities of the workforce, which is sometimes very different from what we have in the paper, what we have in reality? So we call really this the dilemma of accountability in the loop. Where is it? Where should we really go to?
To resolve these dilemmas, we must ground our work in the WHO ethical framework. There are two documents that you should check out, and it's also part of the reference at the end of the slide deck. This consists of six consensus principles. First, protect human autonomy. AI must be decision support. It's never a substitute for clinical judgment. Second, promote well-being and safety. That is, we must meet strict regulatory requirements and do not harm protocols. Third, ensure transparency. The internal logic must be explainable and documented. Fourth, foster accountability. That is, stakeholders must remain responsible for safe use. Fifth, ensure inclusiveness and equity. Designs must avoid bias and serve all populations. And finally, to promote sustainability, AI must align with the long-term sustainability of health systems and the environment. So you can see that it sounds sort of like ideal, maybe, but we really do need this framework to align AI systems in global health. We cannot discuss the future of AI without addressing something that we all think about, and it's been said over and over, and for a reason, and that is the sustainability imperative. As you can see, as you already know, high performance AI models require massive computational power. It uses a lot of water and it might pollute a lot, resulting in significant energy consumption and carbon footprints, also water use. This creates a cruel irony. The very tools intended to solve poverty related diseases may contribute to the environmental degradation that indeed exacerbates poverty. Then we must ask ourselves, at what point does the environmental cost of an AI tool outweigh its health benefit for the poor? This is not just an operational question, it is an ethical boundary we must navigate carefully. Here we have sum up some strategic non-negotiables. It's not comprehensive. It's some that we think we should think about, but we can keep on adding some. I do invite everyone to add some other non-negotiables to this list. But to navigate these ethical waters, we propose a set of strategic non-negotiables. First, we must move beyond the pilot and integrate AI into national strategies from day one. Second, we prioritize Edge AI for rural outreach to bridge the connectivity gap. What is Edge AI? It's the ability of a mobile phone or a mobile device to also work offline, not necessarily all the time connected to internet. Third, we demand mandatory bias audits and local validation before any deployment. We must also uphold data sovereignty, especially when working with specific communities such as indigenous communities, for example, ensuring fair benefit sharing and securing a community social license. Finally, we need clear accountability mechanisms, that is governance that prevents vendor lock-in, and a commitment to post-deployment monitoring to catch model drift before it causes harm. Just to mention some of the whole list that we have here, but definitely you might want to add some others to this list. Let's take a look at AI education. We're going to be using Myler's pyramid. Implementing these non-negotiables requires a new kind of workforce. We propose using Myler's pyramid to structure AI education for health professionals, for global health professionals such as all of us. It starts at the base with know, understanding the basic concepts of AI, machine learning, data quality, and so on. It then moves up to knows how, the ability to reason, evaluating the safety and bias of these tools and all the ethical tensions. Then comes shows how, hands-on practice in simulated clinical encounters. These simulations are getting easier and easier as computation increases. And finally, the pinnacle is to integrating AI into real world clinical judgment with full legal responsibility. It also requires governance, ethical frameworks, and the ability to do it, infrastructure, and so on. But that is the last part, the do part. Our goal here is clear: create AI literate health workers, not computer scientists. We do need computer scientists, but we also need a health workforce that is absolutely literate on how to use AI.
And so, with all this in mind, we need to look ahead. What is the future in AI in post-related disease research? So, the trajectory of AI in this area is defined by six key areas. First, we will see institutional and strategic scaling, moving from experiments to policy. Second, AI will drive accelerated drug discovery, especially for resistant pathogens, something very, very prevalent nowadays. Third, we anticipate genetically tailored therapeutics that respect global diversity. Fourth is the reinvention of point of care diagnostics, bringing low quality analysis to the field, something that is working now, but still there are some gaps that really need to be filled out. Fifth, AI will be central to One Health and integrated surveillance. And finally, all of this must be underpinned by data sovereignty and local co creation. So, this will ensure solutions are owned by the communities they serve, right? So, basically, these will be kind of like key areas that we're going to see developing in. So, before looking into the future, we want to share with you a little bit of the success of our recent initiative with TDR Global. And it is an introductory course in AI in research and grant development. So, with this introductory course that we did last year, we targeted early and mid career researchers, specifically in South and Southeast Asia, working on priority global health challenges. The profile was diverse. We had 15 participants from countries ranging from Bangladesh to Thailand, with very diverse backgrounds in infectious diseases and health systems. And basically, the course aim was practical, moving from idea generation to grant submission. So, what we did was over 4 live sessions, we established an 11-step reproducible workflow. Here, we didn't just teach the tools, we very effectively used the tools, we navigated the ethics and authorship of AI disclosure as well. And this successful pilot proved that researchers in the global south are ready to adopt these tools immediately to level the playing field. And this, to our experience, was very successful in doing it as a first introductory course. Now, building on that success, we are launching our 2026 roadmap with first we're launching the new version of the introductory course, and then we're putting forth two advanced courses. One will be AI support evidence synthesis, the one that we're showing here. So this is designed specifically for TDR and WHO aligned research. And the aim in this advanced course is to empower researchers to conduct methodological, robust, transparent literature reviews. So basically here we are moving beyond basic searching to using tools like Research Rabbit, Elicit, and Ryan for systematic rescreening and structure. The curriculum will cover the entire life cycle of a systematic review, from mapping reviews, types, refining questions with AI, to risk of bias assessment and evidence mapping. Crucially, the final module focuses on ethics and consolidation, ensuring that every AI assisted step is documented transparently in the final review package. That's one. The other one is following the evidence systems. We introduced AI power proposal development and workflow automation. So this course is about translation, taking basically that synthesized evidence and turn it into a competitive winning proposal. We use advanced tools like Claude artifacts, Gemini Advanced like GEMS to build methodological backbones and logic models. A key innovation here is simulation. So we're going to use AI to simulate a skeptical reviewer, allowing teams to stress test their feasibility and budget narratives before submission, something that I believe is very helpful. And we also focus on workflow automation, helping labs build custom, reusable AI assistants that can handle repetitive administrative tasks, freeing up more time for actual science. And we all know that administrative tasks can be a very heavy burden when we want to do project research or science in general. So hopefully we can develop these three courses, let's say, in this year.
And this brings us to the end of our presentation. We have traveled from the high level ethical frameworks of the WHO to the practical on the ground training that empowers researchers today. AI is not just a tool, it's no longer a tool. It is a new literacy that, if governed correctly, that's what we hope, can dismantle the barriers of poverty and resources scarcity that hit so much our regions. We invite you to join us in this mission, whether through our upcoming courses or by collaborating on the ethical deployment of these technologies. Please reach out to us in case you have a question. Thank you to TDR Global for organizing this session, this seminar, and all our partners for your constant support. We will now open the floor to some questions in case you want to post them in the chat. We can have just a couple. If someone wants to, let me just check. I'm going to close here. So we have a reflection here that says, where is it? Did it? Do the governments have the ethic and AI regulations and laws to be complied with organization implementation, or just use international perspective? Oh, that is a great question, because what happens often is that there is this guidelines, these international guidelines, but then these guidelines need to be translated into an actual set of national regulations. And many countries are moving towards that idea. The European Union has done it quite well. They have to change it because it was too restricted. But yeah, it depends on the country you're mentioning. Some countries have do evolved into developing these regulations. Some others are just in zero. They are starting from zero. But it will eventually happen, as it did happen for data security, data management, for example, for health information systems, and so on. These frameworks are just being developed. But while that happens, then the question is, what are the risks if we deploy AI on the health sector without having an actual framework? That is indeed a good question, and there is not a good answer, because if without a framework, then do we wait until we have the framework? But the thing is that AI evolves so fast, incredibly fast, that once we have the regulatory framework, then the AI infrastructure, the AI platforms are just so different that we might need another framework once it is there, it is here with us. That is one of the challenges now with AI. Let me check.
If I
Yes,
can add
yes,
a little
please.
bit more on this question, in my case, let's say in Guatemala, again, this policy development on the use of AI is very weak. It's just starting, but we have seen a shift now. Governmental institutions are looking into developing now this before, let's say, time is too late, and we're hoping to help in developing the use of AI in certain institutions at the government level in Guatemala as well.
Yes, we've been supporting already a couple of institutions and countries working out the AI roadmap to in within the health sector or in healthcare. So we have here Ted. In your view, is it likely that wide-scale deployment of AI in public health in the global south will be driven by public systems or by private enterprises for profit? If the latter, then the ethical guardrails that you outline in the presentation may prove very weak indeed. Yes, that is also a great question. One of the issues that we are facing in the global south is that many of these platforms are not from the global south. So the servers, the platforms, the deployment, in many ways, they will come from the global north. And then these ethical guardrails definitely may be too weak, and we would need to develop our own guardrails and ethical framework to face this. And I love that you're mentioning this because there is one of the guidelines that talk about equity, but it's more about the variety of populations where the AI platforms might be deployed. But we do need to think about what it is for us from the global south to have this AI coming, right? And because the infrastructure is from rich countries, they will handle the data. They have the training, the knowledge, the know-how. So how can we actually do it in the global south? Yes, we will need to definitely develop our own guidelines and for our own institutions, and that goes directly to the previous question of having a national regulatory framework. Great question. Nina says, how do we engage policymakers, healthcare workers, as well as community members responsible use of AI in healthcare? It's partly activism, but it's also from the top level that there has to be a need to definitely make this happen. But make this happen not only from the technological point of view, but also make this happen from the ethical and regulatory point of view. So we do need the intention of policymakers wanting to do this from these two sides of the spectrum. Same from our perspective is that we do need to be activists, really pushing the ethical use of AI platforms in healthcare, but being trained and getting into this type of courses that we're offering. But beyond that, really getting to know what are the possibilities of AI. You don't know the challenges of a tool unless you really use it and experiment with it. So giving our backs to AI is a bad idea because in order to understand the potential, but also the risk, we need to be trained on these technologies. So keep learning, keep training yourself into the use of AI in the health sector, definitely, but in general in your life, because the risks are there, but also the potential. What
And
else? Yes, please.
if I can add a
Yes.
little bit more, I mean, this question is very interesting because there are so many different level of key, let's say, stakeholder actors that you can engage with. So from policymakers, you had to engage them in a different way than the community health workers because we have to always remember that there is a technology gap between one actor to another. So we really need to think about how we're gonna engage with all of this on a different ways. Like, for example, it's very easy to engage uh, key members from governmental institutions or international institutions that provide access or help to communities, but then local actors or communities, then that's a different question. And that's, I guess, there's a little bit of work to do there to effectively engage community health workers in this case.
Hmm. Thank you, Carlos. And then Leslie is asking here, is there a tool already available to assess countries' capacity readiness to deploy AI tools? I would imagine that adoption involves phases, where a country can adapt certain AI tool based on their capacity readiness. Yes, there are different tools, and in general for digital capacity of a country. For example, the Pan American Health Organization for the Americas developed a tool to assess this capacity, this availability, this readiness. But I do encourage you to reach out to your office because they have developed it, but you have to use it to check it and then adapt it to your own situation. So because there are different levels of readiness that one must have to take into account. One is the national readiness, another one is the state or district readiness, and then that goes on to the clinic or the health facility readiness, and all of them have to be run in order to check whether it is indeed possible to deploy this AI tool, but also what are the risks given that context. If you text me, or if it's a possibility to we can share it to everyone who's attending, some of these tools that are there being developed. These tools change over time because AI technology is also evolving way fast. Like for example, the first guideline from WHO is was from 2021. That was before LLMs. LLMs already existed, but when ChatGPT 3.5 just suddenly came up in November 2023, it changed everything. So they fast needed to create another guideline that was recently launched. So these tools do work, but I definitely do encourage you to tweak them into what is happening in your context. And in ministries where frontline staff are already overstretched, how do we design AI alert systems that reduce burden that rather than shift accountability onto health? Yes, that is a great question. One of the problems with a lot of AI alert systems is that if you have way too many alerts, at the end it numbs attention, and it tends to have the opposite impact. Yeah, that's something that has to be done through studies and assessments on how many alerts is way too much and way too many, or too few. But the problem, which is another aspect, is the accountability problem. That means what happens if the health worker decides to use an AI platform and then something happens to the patient, right? If someone dies, for example, from the use of an AI tool. That risk is a problem because we cannot really find who is accountable in an opaque system, because we don't know how the decision process was made, and the whole spectrum of the AI deployment often is too diffuse. We cannot really know whether it was the system in itself, it was the decision process at that very moment when you used it. It was maybe that the health worker fell into the trap of automation when it just stops really overseeing and controlling the decision that is coming from the AI and just accept it as it is. It's very difficult, and definitely that is something that we're trying to everyone that is into AI for health is trying to solve, because that is a big issue that we are definitely facing. I have no answer to that question, but that's something what we really need to have to take always into account. And Takao is answering, in a small island settings like Fiji and similar Pacific contexts, surveillance teams are small and often manage multiple programs simultaneously. Outbreak response, routine reporting, lab coordination, internet connectivity. Yeah, yes. I mean, ideally, AI should facilitate taking this burden from health workers when it comes to surveillance. But sometimes just getting trained on using AI increases at the beginning a little bit the burden while the people are getting used to the tool. But then over time, because there is this literacy on the platform, on the tool, then it should decrease. But yeah, that is definitely a great topic. Poverty-related diseases, my suggestion is we use a better recommended wording that is disease associated with socioeconomic disadvantage. Yeah, one of the things that thank you, Mohammed. One of the things that we've been doing is mapping the many ways several institutions have been using this concept of diseases that are affected by poverty in this cycle that Carlos explained to us. But thank you so much for the suggestion. I think with this
Yes,
one
thank you.
we close the session. Of course, we want to have our always group picture. So thank you so much. And for those who can turn the camera on, that would be amazing. We have a lot of people, so we will need to smile over and over and over. So kind of raise your smile. Yes, thank you. Thank you so much.
Aku yang ngomong dek, jangan mainan di situ dek. Kamu cacingan.
Agi, if you don't mind helping us with the pictures, because we will have to take three of them, I guess, because I can see
Yeah,
three screens here.
yeah. Let's take a picture, everyone. So, wait a minute. I will switch the view. So, Anggit, please help us also with the picture. So, I'll
Thank you.
spotlight
Who
you
else
and
can
Carlos
turn the
first.
camera on?
Can
Ah,
everyone turn their camera on? As for light, wait.
Okay.
Oh, we will need to remove the wait.
yes, yes.
Yep. Yeah. Now it's view gallery. Okay. So everyone, open your camera and smile. Okay. One, and then two, and then three. Yep. We've taken
Super. Thank you
it.
so much. Thank you so much for coming to
Thank
this
you.
session. It's been a real honor for our colleagues, and it's amazing. I hope to see you very soon. And we're just gonna be jumping then to our next session. Agi?
Yeah, so everyone, thank you so much for coming in. We're very sorry for the slight inconvenience. We have a minor error, and thank you so much for staying with us. Before you leave, please fill this form if you wish to receive your e-certificate. We can also send the materials through your email through this QR. So please feel free to fill this form. And for those who are selected for the speed networking session, please kindly stay. We will take a short break and then we will resume this session in 10 minutes.
Thank you.
Thank you so much.
Thank you everyone.
Thank
Thank
you.
you, everyone. Thank you so much.
Okay, so is everyone here? Yep. Hi Felipe, hi Malida. So everyone, hi, good afternoon.
Everyone.
Hi Rizna, nice to see
Hi,
you again.
Maggie.
So anyone else already finished their break? So yeah, if you're uh, a bit shy, please open your camera so we can get to know each other better for this speed networking session. So yeah, some of you is a very familiar face of TDR Global Asia. I've seen some of you before, and some of you is new, relatively new. So that's okay because we'll get to know each other better. So a little bit of this session. And this is actually a new experience from TDR Global Asia. We're trying to have this speed networking session especially for researchers and um, academicians and practitioners who are interested in ethical and responsible use of AI in research on poverty related diseases. So, as usual, we have Felipe and Carlos with us, and we also have Marida from TDR Global Asia. And this session, we're welcoming participants from Pakistan, India, Nepal, Fiji, Indonesia, Myanmar, Nepal, Sri Lanka, and Philippines. Actually, there's a lot of you, but some of you are not present yet. But that's okay. I will check if anyone joined later. So yeah. So wait. So perhaps for this session, uh Felipe and Carlos, Do you wanna
Yes.
say a little bit something?
Yes, of course. Thank you so much. Thank you so much for participating here to this speed networking. While Carlos shares the presentation of the exercises that we'll be doing, have ready, if you have a LinkedIn, have ready your link to your respective LinkedIn, because with the people that you're gonna be exchanging some ideas, you can just share to them your LinkedIn or your contact. That's kind of the point of networking. So Aggie, can you stop sharing, and then Carlos is able to share the presentation?
Yes, thank you.
Yes, thank you. So in this moment, we are 20, like 17. So just to facilitate the process, to analyze these cases that we're going to be having, I also have them. We're going to be dividing ourselves into two groups. And then, all right, and then in two groups. Okay, perfect. So just let's check the situation. So basically, what we want to have is a T-shaped research career. So combining deep health expertise with AI literacy. The goal is to solve, well, it is not to solve, is to explore real world career tensions across 2025 and 2032 strategic horizon. So think about what's to come. And it's going to be interactive. You can just share your thoughts and practical leadership. So let's just check the scenarios. The first scenario, if you can just go to correct, is the field researcher. So it's about deploying an AI diagnostic tool for skin NTDs that it's 10 times faster than humans, but misses 15% of cases on local skin tones due to training bias. So the data that was fed is biased. What is the challenge? Does the benefit of screening 1,000 more people justify the risk of this misdiagnosing 150? You have to kind of think about this situation. And the ethical question is, are we accepting second best tech for the poor? The second level would be the manager, where you are integrating AI into a national malaria surveillance system. This AI predicts an outbreak, but the district lacks the digital infrastructure to verify it in real time. So, what is the challenge? How do you lead a team to trust an algorithm when ground truth data is 3 months old? And the ethical tension would be, there are many others, of course, but we're just mentioning this. Do you spend your budget on smart servers or on manual workforce? And the third and last, a prestigious global North university offers to fund your TB lab, tuberculosis lab. They want your 20-year patient database to train an AI. In exchange, they offer mentorship, but keep the intellectual property. The challenge, what is the long-term career cost of losing your data sovereignty? With the ethical question, how do you ensure for benefit sharing for your local institution? So that's basically what we want you to discuss. We will be there just in case you have a question, but this is something that you will have to discuss and face in the group. So Carlos, do you mind creating or Aggie, if you don't mind helping us out creating the two breakout rooms?
Yes,
We're
we.
gonna do it in two ways. The first group, and then we're gonna repeat the same experience, but ideally with people that you haven't been with. So let's do it with the first two groups, if you don't mind, Agia, or I can also create them.
Yeah, we already created the breakout rooms. Do you
Super.
do you wanna assign, or do you wanna self assign, or?
Yes, I think it's a good idea to self-assign it.
Oh, yeah, I will open all rooms and uh,
Okay,
join
super.
whether they want to pick in the room one or room two.
Yes, make sure that you know which room you are joining, because the next time you will join the other.
Yeah, so we will rotate after this. After your
Yes,
discussion in room one finish, you will rotate to room two and vice versa.
correct. So please do join. It's going to be fast, this
Exactly.
session. So we will
Exactly.
have 10 minutes and 10 minutes, around 10 minutes. You should have received the invitation, but I don't see no one joining. Can you confirm that you have received the invitation? Leslie, Yocha, Nashna, no?
So if you're not, wait, let me.
Maybe like easier to kind of like assign them.
Okay, let's
Yes,
let.
I will
That
do
I think
it.
that will be quicker. So Carlos and Felipe, we kind of like split you into like the first and the second one,
Okay,
and
I'll be in the
the
second one
rest
then.
also. Mm-hmm.
Yeah,
Okay.
okay. First is okay. So 10 minutes and then we go and join the other 10 minutes.
Thank you so much for everyone coming back to the session. Let's just wait for the others. Aha, Mohammed is sharing his LinkedIn. Let's wait for the other people to come. Okay, now they're coming right now.
Yep, we're
Yes, thank you so much. Thank you so much for coming. We're waiting for the others to come. So, how was for the other group? Just a debrief here. We only were able to approach the first scenario. How did the
The
other group
same,
did? Yes,
the
aha,
same.
aha. Okay, so once we go to the other group, you will have to choose either scenario 2 or scenario 3. But we're gonna be doing something a bit different in this second group. Is that you will say in just one word what is your expertise, such as I'm an IT health, I'm a TV researcher, I'm a and Carlos will assign someone randomly who will lead the group. I will do the same. Okay, in the first one, it might be that no one knows who's who, but in the second one, we will know in advance who's the person in charge and what are the sort of like but super fast. What is the main expertise that everyone here has? All right. So now let's go to the second group and up to you to choose either a scenario 2 or a scenario 3.
Got it.
okay. So let's open the rooms. Uh, we will change the. So I will move Malida and Felipe. Felipe, I will move you to the first room. Wait.
Wait, so it seems like we are
Yeah,
both like choosing our own group, right? Isn't
yeah,
it
yeah.
Felipe and Carlos?
Yeah, I will just move. Is it? No, no, no. It's I will move Felipe
Um,
and Carlos to the other room. So
I go to room 2, right?
yeah, you go to room two. Uh I will move Felipe to room one. So
Okay.
you go to room two. Malida, you go to room two.
Could
Eh,
you move me to room 2? Because
room
I'm not
room
seeing the
one.
invitation.
Do you want to go to room one or room two, Malida?
Well,
Well, it's fine though.
Okay, so Carlos will move to room two.
thank you.
Thank you. Okay, so great progress, everyone.
Thank you.
So
Let's
how
just, everyone is here back? No.
yeah, yeah. So how about having a light talk since we have quite late start? We can extend the session
Yes.
in 20 minutes for light talks about everyone's interest. So it
Let me just share this one for the third scenario.
where they're from, how their interest and some
Yes, here. Okay, so let's just wait because I can see. I think someone's still in the breakout room.
I don't think so, but the room two still in the a very very in the middle in important discussion. I think
Okay, but we
so.
need to. Okay, so it's they're coming. They're coming.
They're coming, so
Yeah, let's just wait a little bit till they join right now. Yes, they're joining right now. Okay, so after having this discussion, now let's just do some introductions so we can get to know all of you. And thank you so much for this discussion. Really interesting, your points of view and insights. So let's just start with Asha, if you don't mind introducing yourself. Keep it short, not more than a few seconds. Like it's difficult, I know, because we all do so many things. But yes, please.
Okay. Thanks, Philip. I'm really sorry because I cannot
It's all
talk
right.
much because I'm driving also, and
Ah,
for the moment I stop and attend for this. So, okay, if I introduce myself, I'm a senior lecturer in animal biotechnology. So I'm teaching both vector-borne disease control research related to biotechnology field. So the diagnostic also, and I'm working in vector control research as well as diagnostic research in for the time being. And my main target area is leishmaniasis and dengue. So at the same time, I also would like to use AI technology for vector surveillances because I'm practicing vector surveillance in rural area, especially where we don't have that much of healthcare workers to do this surveillance work. So I managed to work with our IT department. So we have a separate department involving these AI technologies. So we set up some traps to catch these vectors. So the trap model also differ, and so we can in this research work I hope to have some idea about what are the possible disease vectors present in that rural area where there is no such data available in Sri Lanka. So we use these traps for collection, and then we ask our community, we train actually them to get some images from their smartphone and share with us, and we are now trying to identify based on their images using this AI technology. So I'm much more interested to uh, learn how I can precisely use this technology, because when we get these images, there are so many things we need to
I'm sorry,
improve.
Asha. I'm sorry to interrupt you, but we need to go through 13 people and we don't have
Okay,
that much time. So I will
uh,
interrupt you here. I'm very sorry. Okay,
it's
we
okay.
need to keep
Okay,
it
sure.
as short
Understood.
as
Okay,
possible.
bye.
Okay, but thank you so
Bye.
much.
Okay.
All right, thank you. So, Asha, thank you so much. Vishal, if you can introduce yourself, but keep it very short.
Okay, thank you. My full name is Bisal Dahal Kadri. I'm a climate health researcher, and I'm currently studying at UGM, Faculty of Medicine, in Masters in Public Health. Yep, thank you.
Thank you so much. Dr. Aung Tan, can you please introduce yourself? Do you hear us? Okay, in the meantime, let's go to Vyochna from Nepal. Can you please introduce yourself?
Um, yeah, hi, I'm Dr. Jyotsna Sapkota. I'm a microbiologist and I work on dengue diagnostic research. Nice to meet you all.
Nice to meet you. Thank you so much. Leslie?
Hello, everyone. My name is Leslie Olmido. I work as a consultant with the WHO Wipro, now working in the Pacific island of Tonga in non-communicable diseases. Thank you.
Super. Thank you so much, Muhammad.
Hello everyone, I'm Dr. Mohammed Hakim and I'm a medical doctor and epidemiologist. Currently, I'm pursuing my PhD public health from the Khyber Medical University and my interest is in infectious diseases and health system in Pakistan.
Thank you so much, Nashna.
Hi everyone, my name is Nashna Moharjan and I am currently working as a research specialist at One Heart Worldwide. It's an organization that works in the sector of maternal and newborn health in Nepal, and we specialize in health systems strengthening. Thank you.
Thank you so much, Fugas.
Yeah, good morning. I am a medical doctor. I expertise in clinical pharmacology towards infectious disease, mainly leprosy. Good morning to all. I'm from India.
Great. That was really fast. Rizna, I don't know if you introduced yourself already. Yes. And I think the last one would be Tawake.
Yeah, so hello everyone. My name is Isna and I am currently a student, master student in Universitas Gadjah Mada and previously worked as technical officer in HIV for Global Fund. Thank you.
Thank you so much, Rizna. And Tawake.
Thank you, sir, and warm greetings to everybody. My name is Tawaki. I'm a public health professional from Fiji, currently working in national vaccine preventable disease surveillance. And at the moment, I'm on study leave here. I'm a student at UGM, also with my colleagues Bishal and Rizna on the program of implementation research. Thank you.
Thank you so much for all these presentations, these introductions of all of you. I do have a question to ask to everyone. What do you think AI can really impact your job? Like, what is the actual thing that you see AI impacting directly your job? In the positive side.
I'll go first. And so it's a lot easy now, like in research, if we have an idea and then we have to do the literature search and then like so I find it very easy in that way, like literature search has become very, very easy now. Like we just have to, and then like we can also, once we do the literature search, we can also command like if we need recent data or anything we want to tweak in that. So yeah, I find it very easy now in these days.
Yes, to do literature reviews, no? Like to gather evidence. That
Everything.
is a great point. Yes, thank you. That's kind of a highlight. Who else wants to share? Where do you expect or right now? Please, Puga.
Yeah, actually, my day-to-day activities purely depends upon AI. Starting from the letter writing to the higher authority, I am using the AI. Wherever there is no implication of the plagiarism or AI writing checking, I am using AI. Otherwise, as already my colleague have told, for all the research related things, even though we are expert in that field, for speed up the activity, we are using bystander AI to speed up the process. Thank you.
So definitely, we all see somehow the AI is kind of speeding up the production of reports, analysis, even emails. No one is writing emails anymore on their own. We're all using AI somehow to kind of check it. No, it's amazing that we are maybe sometimes overusing it. Perhaps. Who else wants to share? Where do you see AI already impacting your current global health work?
So shall I share my experience?
Please, yes.
Okay. So, so as I'm teaching, so AI helped me a lot to prepare some lecture notes, giving us some support actually. So I learned more things. If I found any new tools, so I'm asking from AI, ChatGPT, and some other tools I use to getting to know how I can operate this machine or how I can operate these techniques. So it's helped a lot.
Yes, I mean, it's interesting, no? We are, especially because when we think about AI, most of the time we are talking about generative AI, ChatGPT, Gemini, and so on. But there are many other applications, but to a great extent, the one that we're using is definitely generative AI, most likely ChatGPT. And especially, it's interesting that we're having this seminar today because this week both Anthropic and OpenAI just launched the biggest, the most capable models, and everyone is freaking out with these two models. But as it was recommended, there's nothing like paying for one of those because you will have access to the actual model. So keep in mind how important it is to, if you are able to pay for these models. Then where do you see the barrier? What is your main barrier to fully adopt AI tools in your life, in your professional life, and as a global health professional? Who wants to share their thoughts on this question?
One may be the ethical issue, like some of the offices now banned a use of AI, and then we cannot do that in some of the offices. And other is like if as one of the participant highlighted that they are using AI, so it is tricky if we put some data over there, so it is accessible to the AI now. So and the patient data are very confidential, and in health researches we tend to be in that position where we have all that confidential data. So yeah, that can be one of the issue, I think.
Yeah, the question is banning or not banning, no? Like how do we address this? Because for some things it makes kind of sense, but for some others it's just it makes no sense to ban the use because the difference in productivity will be for those who know how to use AI or
Yeah.
who are using it from those who are not using it. So we really need to know what is exactly what we need to ban. Thank you so much. Who else wants to share a thought here?
Yeah,
Uh,
sorry.
yeah, you go ahead.
Okay. So for me, my work in the Pacific, I really realized the low capacity of the people to employ AI because, as you know, most of the health workers there, they're doing a lot of things. They're not just focused on one program. So aside from low capacity, there's also resistance and how they can use this to support their work. So those are the things that we're experiencing. Yeah. Thank you.
Yes, it's like the literacy, no? There are more people who do not have no access to learn how to use AI. Like if one is just sitting in front of ChatGPT, like then what? What do I do with this? Right? So you need to really experiment and to have some case studies and some scenarios where you can see how AI can be used. Definitely, literacy is one of our main goals for both for TDR and for Econex. Thank you so much. Huga, you wanted to say something?
Yeah, yeah. Actually, my major fear is during the time of publication. Like even though we check the plagiarism everything, and even we assume that our AI writing is less than 20%, still we are having fear during the time of submission. Even though we are disclosing, like I have used this tool with this version, still there is a fear that whether the editor in chief may reject our paper or not. So it is there always whenever I am writing some content or submitting for any scientific journal. And one more point, ICJMB, they have given some guideline. But I'm not sure whether all the journals are following the ICJMB guideline. It is mandated to follow, but still there is a fear factor is there. Thank you.
Yes, I mean that is a great point. So we do have some guidelines coming out about how to disclose the use of AI. But the thing is that those are guidelines. Many of those guidelines haven't been really approved or translated into actual regulations or policies, some of those. And the thing is that what comes to many people using AI is that how would they know? If I use, how would my institution, my boss, my team know that I have been using AI? And this creates, there is the ethical framework, but it's also the ethical personal framework of what to disclose. I'm right now facing a situation very similar because we are translating a document, a very long document from Spanish to English with my team. And of course, we said to the institution that we're going to be using AI for this translation, but we needed to first invent how to disclose the every step that we are following to translate. So even if we want to disclose it, the next question was, how do we actually disclose it? What are the steps? What are the things that we need to say? And people are really going to great extents because even for those doing research, they are recording themselves doing the systematic review to prove that they haven't used AI. Imagine screen recording every single step just in case the institution thinks that they have been using AI. This is becoming a bit wild as the extent this is getting, but we're just inventing and coming up with solutions as we go. Thank you so much. Our last question to finish this session would be, what is the principal barrier that you face in your career trajectory? Thinking about the future, what is the principal barrier? Write it in the chat. Think about it, but write it in the chat. What is this barrier that the future holds in your professional career? Not exactly getting? What do you mean, Puga, with that? You're not exactly getting any barrier for your professional upcoming career
No,
No,
I
no, I'm
guess he
trajectory?
asking.
wants more example.
Yeah, like if you
Ah,
can share the your experience so that we will come up exactly what you mean to ask.
yes, like for example, a professional barrier would be if you decide or you're just thinking about living in a very remote, small area that maybe is a paradise, but in that area you won't have access to infrastructure. So you will be sort of like lagging behind a little bit from what AI has to offer because of lack of access to infrastructure, to AI infrastructure. That would be something. Lack of
I
trust in
can
AI. Oh my God. Yes, Carlos, please.
Another example would be, I guess in my case, the main barrier would be that if I want to implement AI tools as in my teaching that I do in my university is a public university, so it lacks a lot of budget, facilities, and infrastructure to actually implement it. So, by the simple, just to give you an example, we don't have internet access in the classrooms. So how do I implement AI tools with such lack of resources to do it? That would be kind of like a main barrier for me.
Yeah, that's an interesting one. It's not the same if it's a governmental university in the global south than if it is a private one, right? Lack
Completely.
of trust in AI. This is something now it's hard to trust even anything. Like if you see a video, a photo, do you even know it hasn't been AI created? Now there's this AI video developer called Seed Seed AI, I think was the name. It's just beyond. It was launched this week. You won't believe your eyes. It's impossible to tell. It is impossible to tell. So imagine flexibility and adaptability, how quickly we can pivot to these AI tools. yes, not only to pivot to these AI tools, but once we pivot to some of those tools, how to pivot from those ones to another ones. Because the thing is that it's changing way too fast for us to really be able to catch up. Updating yourself, like educating yourself in AI, is proving to be a challenge because you do it and then in a snap, then everything has changed and then you have to relearn everything once again. So it's a challenge. Funding, as Carlos just mentioned, how it is going to be for the global south to really find funds to for these projects in AI will really remain a challenge, and yeah, countries will have to find ways to have specific sources of money for this, as they did for internet and as they did for electricity. Yet, many people in the world have no access to electricity, right? So imagine we're still in that moment and we're thinking about access to AI. Not getting proper AI expert as most of the time I lost it in dealing with clinical data. Yeah, expertise in AI, especially because AI is like everything and anything. So what it is to be an expert in AI, it's like a set of expertise, right? Many people coming from different backgrounds that will definitely provide the expertise of AI, but one single person acting as an expert, that doesn't exist and won't definitely exist. Over reliance on AI could reduce our judgment. Yeah, I always use the example of a calculator. That if you in a calculator you do something like 8 plus 13 and then it says 20, will you trust the calculator or will you trust your own judgment? Because that is what it is called, the automation bias, when we tend to believe more the machine than our actual brains. So yeah, that is definitely a problem that is happening. Lack of skills, and that's why in 2025 the word was slop, no, AI slop, when whatever output the AI makes seems to be amazing, but once you get into it, it lacks depth and quality. Skills using AI, definitely. Another barrier is cultural, the perception that AI threatens professional expertise. Yes. And you have to, I will send you, I will, because we're going to have a group, I will send you a link to an article that was published in Twitter, but by one of the key CEOs in AI in the world, just kind of announcing that 2026 to him is the year where everything will be just accelerating extremely to an amazing change that is hard to foresee. I don't know. I don't really know what actually will be the workforce in the future. But for those who prepare and learn about AI and experiment with AI, will have more ways to defend themselves, right, from whatever is going to happen. And then to finish, in my context, I see AI more as a tool to reduce repetitive workload and support decision making rather than replace surveillance officers or frontline staff. Yeah, I mean, that is the hope in a great sense. Nowadays, still, it is a tool, and it's what it is called the human in the loop. But it is also true that, for example, the latest model launched by Anthropic, Claude 3.5, if I remember correctly. The CEO just said that almost all the code lines were developed by the former model, AI model. So they are not using as many software developers as they did. So let's see what happens. How many of our tasks can be automated through AI to the point that it creates risk on our jobs. And the idea is not to replace humans, but some people are really getting anxious about this possibility. But it won't happen, at least not that fast, for those who are AI literate. So learn about AI. Don't escape from it, right? Don't give your back to it, all right? So just to close this one, I will call Malida and Aggie and Carlos. If you guys want to have Carlos one final reflection on this session and on AI, so please.
Okay, thank you, Felipe. It was a very nice session. By the two, when we divide it into break rooms, I mean, it's amazing just how one case can start a lot of discussion on both break rooms. We only discussed one case, and it wasn't enough time to discuss all three. But I mean, this is kind of like there's still a lot of questions. There's still a lot of countries, mainly in the south, that are starting with this, and I guess it's the way to, as Felipe says, look into it. Don't turn your back into it. That would be my takeaway. But there are certain limitations that we had to take into account in order to fully implement AI tools in our respective areas of work. Thank you for the session. It was great.
Thank you, Carlos.
Yeah, just
And then
adding
to
what was
close, Malida, please.
yes.
Thank you.
I mean, like, thank you so much, Felipe and Carlos. Thank you so much, everyone, for like registering and also participating. This is like our first speed networking for TDR Global Asia and supported by Felipe and Carlos also. And so excited. I think like AI in research is kind of like a new theme, new approach, and there's a lot of like kind of issue with ethical and stuff. So I feel like TDR Global Asia would like to kind of like addressing this issue with kind of like facilitating like researcher from like CRO and also WorldPro to kind of having a discussion and everything. So I hope that this speed networking is just like a short beginning to kind of like a more connection, more collaboration in the future. So thank you so much for like today, and I hope that we can still continue the discussion and like connection through like WhatsApp group and also like from LinkedIn. Thank you.
Yeah, so since it's my turn, then it means we're coming to a close. So I will send you something in the chat room. Uh, So yeah, we compile your socials. Please do network and collaborate with each other in the future. You can find the LinkedIn to people from here. Also, perhaps if you're a bit curious, we have the Orchid or Google Scholar link. Perhaps collaboration opportunity is on the way for some of you. Also, kindly we ask you to fill some evaluation form so we can learn from your experience and how to bring a better speed networking session in the future. And we also have a WhatsApp group, which some of you might already join from the previous class. So this WhatsApp group, we want it to be a networking room for researchers interested in AI for tackling diseases and poverty through innovations and research, especially for TDR Global Asia members. So please, if you are active on WhatsApp, feel free to be active on the group. Sometimes we share informations about latest updates in AI and health. And yeah, it's very interesting to meet you all today. We hope to meet you all soon again in
Yeah.
another opportunities.
Just add one more thing, follow our social media and newsletter. So Carlos saying about like future class on in AI, and like we would like to share the news soon through the like newsletter and social media. So stay tuned, and also we will share it to the group for sure, WhatsApp group. Thank you.
Yep.
Thank you
So
so much.
thank you so much, everyone.
Thank you, everyone. Such a
oh,
pleasure.
Thank you, everyone.
thank you, everyone.
Bye bye.
Bye
Yeah.
bye.
Bye bye.
Thank you. Bye bye.